Hello, precious mamas and mamas-to-be. Welcome to my mind-opening interview series with important authorities in the birth world. This is your host, Ilka Bee, with the Liberated Birth movement, broadcasting from around the world. In this interview series, we're going to once again uncover myths, ask interesting questions, and get out-of-the-box answers. Hello, hello.
Can you see me?
I cannot see you, but I can hear you.
Well, how come you can't see me?
Let me see. It says, oh, here you are.
Okay, yeah, there was a red line on that. Hi. How are you?
Hi, good to see you. How are you doing?
I got monkey headphones on, but that's just the way it goes.
That's perfect. Are you in LA?
Yeah, I'm in my apartment.
Perfect. Yeah,
Where are you?
I'm in Hawaii here right now.
Oh, you're in Hawaii.
I'm in Hawaii. Yes, it's a beautiful day out.
It's Hawaii.
Yeah, I mean has been raining a lot in the last few weeks. So
which island?
Big Island.
You know, I was just there in February for 2 weeks for a week.
Nice.
I gave a course with the Go Midwife class.
That's perfect. See, I'm sad I missed that. I was in Sacramento then. I'm only here. I think I started being here in beginning of March. Yes, and we're going to actually go to Asia in 2 days. So I'm glad I'm catching you still in America.
What are you doing in Asia?
Just traveling around right now.
On holiday? Okay.
Well, we're going to travel around for like the next, 4 to 6 months, and then actually come back to California and have our baby here in October. So
congratulations.
Thank you. Yeah, I'm actually having a rough day today, but I'm getting myself together because I'm really super excited to have you on here and ask you a few questions. Because I am doing this wonderful interview series with people that I believe are like birth authorities, and you're definitely one of them. So please, Dr. Stuart Fischbein, tell me a little bit more about who you are.
Well, first let me ask back questions on you. We met at the Indie Birth Conference.
Exactly. Actually, I came across you on YouTube, which was really interesting because while I was in midwifery school, I had one evening where I watched breech birth videos, natural breech birth videos. And, usually you only see women there or maybe the partner. And at some point I saw some male hands coming into the video and I was like, what the heck? Who is this? And this male hand delivered the baby, the breech baby. And so I was like, oh my God, that's so strange. Like, is that grandpa or like how is this man related to this family? And so I looked you up and I was a breech myself. So I was really interested in breech birth. And and then I met you at the Indie conference in Sedona. That's right.
Right. So are you recording this conversation?
Yes, this is going to be recorded, and I would like to spread this. You can use it on media wherever you want on your website or share it with colleagues. Okay. But for me, it was important to have people together that bring people together that have a little bit of a different opinion about what birth is. Since 99% of all women give birth in the hospital, and I know you were actually a doctor in a hospital before.
For most of my career, yeah.
Exactly. So please tell me, how did you decide to all of a sudden overnight become a doctor or become a male midwife, basically?
Well, it's a little more complicated. I have to go back in time just a little bit. And excuse my voice a little bit. I'm still just getting over a cold.
Thank you for being here. I appreciate it.
You're welcome. I took the usual track for a medical school and residency that almost every other physician takes. I wasn't different in that way back then. I was different in certain ways. I challenged authority when I didn't understand why we were doing something. I've always done that ever since I was a little kid. I went to the University of Minnesota Medical School. I did my residency in Southern California. Back in the early 80s, I was a chief resident at Cedars-Sinai in Los Angeles. As part of our training, we spent 4 months at LA County USC Hospital. And in the early 80s, that was the busiest hospital in the country. They were doing about 22,000 births a year there, which turns out to be, that's about 65 a day.
That's like an In-N-Out burger.
It was a mill. It was a mill, but it was a great way to train because we got to do everything, and it wasn't under the strict supervision or strict risk management protocols that residencies are in today. So
Mhm.
I got to learn the skills that make obstetricians unique, such as forceps and breeches and breech extractions of second twins and dealing with all that sort of thing, and not looking at it in a very nervous, scared way, but looking at it as part of the standard training of obstetricians. And so when I came out of my residency program, I started a private practice, which is what was more common back in the early 80s than it is now. I think now most doctors come out of residency programs and look for a job so they can work a shift, and it's not the same thing. It's you're not captain of your own ship very often in medicine anymore. You work for somebody. But when I did it, we were still captains of our own ship. And so I was able to do pretty much all the things that I had learned in residency. I was able to practice those skills in private practice. And shortly after I came out in practice, I was approached by a couple midwives in the community to act as their backup physician.
Mhm.
And of course, I didn't do it out of any sense of loyalty to midwifery or anything like that. I did it because I was trying to build a practice, and it was just a way to generate revenue for me and to expand my practice and my exposure. And I would say that I did that for about 10 years. And then I realized at some point that it would be really nice to have some sort of passive income. And I decided to set up a collaborative practice with two certified nurse midwives working in a hospital-based environment where, the midwives took care of the low-risk stuff and I did the high-risk stuff, and I still did the gynecology and the gynecology surgery and all that stuff. But we would collaborate. And, at that point, I'd been backing midwives. I'd seen a different way of doing things. Still wasn't for me. I was still very medicalized in my birth thought process because that's how I was trained.
Mhm.
But during those 15 years that we had a collaborative practice at a local hospital out in Ventura County, I began to see a whole other way of doing things. And I began to, we had to fight every inch of the way against the establishment and against the community and against the anxiety and fear that permeate most hospital administrations, most anesthesia departments, most pediatric departments,
Mhm.
and a lot of OB departments as well. And so there was always a battle going on, but I sort of liked that because I felt that what we were doing was righteous and what we were doing was evidence-based and what we were doing was ethical and followed the model of informed consent and giving women these choices that by right belong to them and not to an institution and not to an individual physician to skew their counseling or ban certain things like VBAC or breech or whatever. And
Mhm.
so for 15 years we did that, but of course we didn't make any friends in the medical community doing that. And after about 15 years, it got to a point where every couple of years you have to renew your privileges. And they were going to not renew my privileges because they didn't like the fact that I was a bit recalcitrant in not following the rules.
Mhm.
Even though I had the credentials to do certain things, they began to ban midwives, ban VBAC, ban breech delivery without any evidence. And I was the sort of the nail that stood out and said, you can't do that. And of course, what do people do to the nail that stands out? They basically pound it back in again. And that's typical of not just me, but anybody who sort of stands up against the larger authority. So it got to a point where, again, I've been working with midwives now for 25 years, and I've been doing no home birthing, but backing home birthing and sort of supportive of what they were doing, but I had never been to one. And
Mm.
during this period of time, this turmoil, I had a choice of fighting the hospital and possibly losing or possibly winning, but winning the right to stay at a hospital that wasn't going to allow me to do what I wanted to do anyway,
Mhm. Mhm.
or leave and go into the home birthing world. And in 2010, I went to my first home birth in August of 2010, and it was delightful.
Wow.
And fortunately, it was delightful. Fortunately, my first 10 or 15 home births were all unbelievably smooth and easy, and it got me comfortable with doing something which I hadn't been comfortable with because I only knew what I knew, which was hospital-based birthing.
Mhm.
So I never looked back at that point. I left the hospital-based world and I started collaborating with midwives, and I don't have a specific midwife that I work with, but I work a lot with there's certain midwives here in town, but all the midwives in the area, and from San Luis Obispo down to San Diego County, all know that I am someone who can be called upon when there's an issue or a problem, or even just for a consult or a question. And that's, so I got into it that way because I wanted to continue to allow women to choose the options that belong to them. And I didn't want to fight anymore. I didn't want to fight the hospital system anymore. And clearly leaving the hospital doesn't mean I'm not fighting anymore. I'm still
Right.
fighting all the time. I'm fighting
Are you
sacrament.
building something new actually on the side, right? That's
Well,
different than getting
I'm
caught
trying to,
and fighting the authorities.
yeah, I mean, I'm doing something that's constructive that gives me a lot of personal satisfaction.
Mm-hmm.
In the meantime, I'm sort of, in a rebellious way, proving that there is another way to do things
Mm-hmm.
and that the outcomes of doing these sorts of things in an out-of-hospital setting are not the, oh my God, dangerous, terrible things that are constantly repeated in the medical community and in the media at large, who only look at birth as as an illness and as something that's bound to go wrong unless thank God for medical intervention, or women would, be helpless and not be able to give birth. And that whole way of thinking is something that I'm, working slowly to change, even if it's just one family at a time. That's what I'm trying to do.
Hell yeah. I'm super proud of you for doing that, honestly,
Thank you.
because apparently it took a very fucking long time to, get that brainwashing out of your mind as well. And I feel like medical school is pretty good in doing that and getting doctors to believe that birth is not something that's normal anymore. I have a few questions, but before that, I wanted to just read you a few words that I wrote down as you were talking because they're so fitting. Okay, you started with, you challenged authority. You had a medicalized, you always had a challenged authority, but you still had a medicalized birth thought process. You were fighting the establishment. You were not following the rules, and you were the nail that stood out. And that's pretty amazing for a doctor, I feel.
Well,
to
see, I'll clarify one thing and say when I'm not following the rules. Technically speaking, I was following the rules, and the rules then changed underneath me. So in other words, I was doing the things that I was credentialed to do, and then they decided that they were going to just, without any due process, going to change the rules. So I have a problem with I respect authority. I just don't respect authority that doesn't deserve respect. And
Right.
and when they do stuff like that, and a lot of it was malicious, a lot of it was personal animosity toward toward me not just kowtowing and bending over. And the institutions didn't like that. And I have to tell you, a lot of the conflict came from outside departments. It came from the anesthesia department. They didn't like the fact that I was doing things that the hospital then mandated, that if I had somebody who was breeching labor, that anesthesia had to be in the hospital, even if they didn't want an epidural. And so anesthesia didn't like that very much. And then I had patients who didn't want vitamin K. They didn't want hepatitis vaccine for their baby. They wanted to go home 6 hours after they gave birth. And the pediatricians had a rule that said any baby born in the hospital has to be checked out by a pediatrician, which makes no sense, by the way, immediately. The newborn babies don't need pediatric evaluation immediately. A nurse or a midwife can do that. But so when a patient of mine came in, delivered at 10 o'clock at night, and they wanted to go home at 2 in the morning, they couldn't go home because the hospital had a policy that said until pediatrics checks them out, and no pediatrician is going to want to come in at 2 in the morning for the the $35 that insurance pays for that sort of a thing. So they put in these rules, and then these rules came back to bite them in the ass. Excuse me, if I can say that on.
Oh, please.
Yeah. And so they were stuck with these things, and so they took it out rather than saying this is a really dumb rule, let's change it. No, they basically went the easy route. The path of least resistance, which was to pound the nail that stands out back in, because every other doctor is complying with these sorts of things.
Exactly.
And even though what I'm doing was what I was credentialed to do, breeches and vaginal birth after cesarean, which of course vaginal birth after cesarean doesn't require any special skill at all, but all hospitals, for a long time made it like, oh my God, these are things that are going to, these women are about to explode at any moment, and we've got to be prepared for that 24/7. And the anesthesia again didn't like that. And then my OB colleagues often didn't like what we did because they didn't do it. And so I think that there's egos involved, and I'll just leave it at that.
Yeah. And you challenged what was. and you ask questions and you challenge the status quo. And people that are acting under the status quo, they don't like that, because all of a sudden they have to ask themselves, well, what am I actually doing here? And is this actually still right? And as you said, there's ego involved for sure.
Yeah, and in hindsight, I mean, could I have done it differently? Sure, I could have done it better. I probably could have, facilitated things better. I probably could have been less controversial or less, contrary, but it was very hard for me to listen to people who, for lack of a better term, I know this sounds arrogant, really couldn't do what I do. And
Yeah.
yet they were the one making the rules.
And apparently nobody still does it, because you're still the only available doctor that does breech and twins and VBAC. And are you doing over 42 weeks as well?
Sure.
And you're doing this at home. So you literally are the only doctor that actually broke free from this. And that
I'm the only doctor. I think I'm the only doctor in the community, in most of the United States, who verbally speaks out for it. There are other doctors under the radar who do what I do.
Mm-hmm.
They just don't want to be known for it, because they take an easier path. Where at this point, there's no sense in me trying to duck my head. Everybody knows what I'm doing, and sooner or later, I imagine there'll be some conflict with Sacramento or whatever else for what I'm doing. But ultimately, everything that I'm doing, I'm following the AMA ethical code. I'm following the ACOG guidelines. The only thing I'm not following is the location of where I'm doing these things. And that, to me, is not my decision to make, or the hospital's decision to make, or ACOG's decision to make. Where to have a baby and how to have a baby belong to the well-informed, honestly well-informed woman. Right. And most women are not getting honest information. They're getting skewed informed consent, which funnels them down the path that the doctor or the hospital wants them to take. They're being only told part of the information. Mm-hmm. And then because there's so much fear in our profession, doctors tend to project that fear. This is my theory, and doctors tend to project that fear onto the American woman. And the American woman fears pregnancy, not because she knows pregnancy is dangerous, but because everywhere she goes, every doctor she talks to, they're all nervous.
Yeah.
I don't know. I'm not an expert in Latin American women, but I got to believe that women in Honduras or Guatemala don't fear birth like they do, like women in America do. Mm-hmm. Mm-hmm. Women in Southeast Asia, it's part of their
Germany.
culture.
Yeah.
Yeah. Totally. I don't know. Yeah. I mean, I'm saying Germany and the Netherlands, I don't really know, but I just can't imagine that there's this sort of anxiety about something that's so normal and so natural, that that is a normal function of a woman's body that generally works well most of the time. And on the rare times where it doesn't work well, or there is a problem, then thank God we have the interventions and the NICUs and the hospitals to deal with. But the idea that every single woman needs to go to the hospital, and every single woman, if she's over 35, she's labeled as high risk, or she's hypothyroid or whatever.
Geriatric. I'm geriatric. Can you believe
it? I know. And just by giving women those labels, you're setting the women up inside their own mind to fail. Mm-hmm.
Mm-hmm. So what would you say was like the biggest difference that you can make up if you say you were 25 years in a hospital, although you were always working or backing up midwives, and then you switched in 2010 to doing home birth? Would you say fear is the biggest difference from the hospital to the home birth?
You mean from my perspective, or the hospital?
Yes.
What do you mean?
From your perspective, like what do you feel like made the biggest difference for you when you are in a hospital setting, or if you're in a home birth setting?
Well, in a hospital setting, I think you feel like there's always a Monday morning quarterback, if you know what that means.
I don't.
Yeah, a Monday morning quarterback is like there's always somebody looking over your shoulder and judging you and evaluating you. Mm-hmm. What a Monday morning quarterback is somebody who, football games are played on Sunday, and the results come in Sunday, and then Monday morning somebody says, well, you should have done this, or you should have done that. Mm-hmm. Okay, so it's after the fact, sitting up in their ivory tower telling you how you should have done something, when those people were not in the trenches. They were not dealing with the issue at the time. They don't know the woman at all. They don't know the family at all. They don't know the dynamic at all, yet they're telling you how they should do something. Not having to deal with that sort of thing, not having to deal with the dumb policies that they have, that every patient needs to have an IV, or every patient has to have blood work when they come in, or every patient needs to not eat when they're in labor, or all that stuff. Not having to deal with that is such a pleasure.
Mm-hmm.
All right. The downside, of course, is that I can't follow my patients who need to be transferred into care. I can't care for them anymore.
Mm-hmm.
And I don't do surgery and stuff. I don't miss gynecologic surgery much, but I would like to have been able to care for my clients all the way through.
Mm-hmm. Mm-hmm.
But that's, in this community, that sort of thing doesn't work. It's very difficult to do hospital-based birthing and home birthing, partly because of the rules of the hospital and partly because of the malpractice insurance and partly because of your call group. A lot of doctors who would normally support midwifery or at least backup midwives don't do so because their partners don't want them to.
Mm.
And ultimately it comes to a lifestyle choice for them of having somebody to back them up or doing what's right. And a lot of people just feel like, I have a wife, I have kids, I have a husband, and I have kids. I can't not have my call group backing me up.
Mm.
And so they compromise.
Mm-hmm.
And they find a way to rationalize that inside their head. There's a cognitive dissonance of ignoring data that is contrary to your point of view, or ridiculing people that take a position contrary to your point of view so that you can feel good about yourself. No doctor goes home at night after doing 3 C-sections in one day saying, honey, I just did 3 unnecessary C-sections today. Okay, they're not going to do that. They're going to find a reason to justify what they did, even if you could look at those as a Monday morning quarterback and say, 2 of the 3 of these were completely iatrogenic and not necessary. Right.
Yeah, there's this controversial thing where then women end up actually like being so happy that they actually had all these interventions that weren't actually necessary in the first place. Right? When I hear women say like, I am so glad I was in the hospital because my baby and me would have died if I would have not had a C-section.
Right.
Right. And often, I feel like, well, did you actually like set yourself up for that in going to the hospital? Right.
Well, this is a cynical part of me, but when I hear a story like that, my immediate response is that it's all bullshit, and that the doctor did something or the hospital did something or they intervened when they didn't need to, and then lo and behold, the baby got in trouble and they had an operating room and they saved the baby with an emergency. When I hear the term emergency C-section, I think emergency C-sections are probably about 1% of C-sections, but you hear it about 50% of the time, because somebody who's in labor and suddenly they decide to do a C-section, they call it an emergency, but it was only an emergency because they overpitted the woman and starved her for 22 hours and did 15 vaginal exams on her and she got a fever. And I mean, there's so many different things that lead to that sort of thing, but you're right. The perception, of course, is, and it's not a bad perception, but you'd like to believe that your doctor has your best interests at heart. And what I would tell people in 2018 is that's not often the case. The individual doctor is probably a good person. As I said, nobody plans to do something evil or bad, but ultimately there's so many pressures on physicians these days, economic pressures, expedient pressures, medical legal pressures, peer pressures, that ultimately they sometimes make decisions not based on what's in the patient's best interest, but what's in the practice's best interest, the hospital's best interest, the doctor's best interest, or just they want to keep their head down, they want to finish their work, they want to go home. Again, we can be cynical all we want, but if you look at the times for C-sections at hospitals, the peak times are like 7 in the morning and 5 in the afternoon. And there's no way that God created labor where labors will stall out at 7 in the morning and 5 in the afternoon.
Right.
They stall out at that time because it's the time before a doctor wants to go to the office or wants to go home for the evening. And so I remember a couple colleagues of mine who gave me advice early in my practice, which I thought was good advice at the time, was that if you can, we have so little control as obstetricians over our lives that when you can control something, you should.
You gotta do it. Yeah.
Right. And so that's why bringing people in at 10 o'clock at night for an induction so that they'll deliver before 5 in the afternoon the next day, doesn't matter that now you've got that woman up all night long. Okay. You're bringing her at 10 o'clock at night so it's convenient for you the next day. Just little things like that, or scheduling C-sections when waiting would be just as good. But if I wait, then she might go into labor at 2 in the morning and I have to get up and come in. as opposed to doing it at 7:30 in the morning and being in my office by 9.
Mm-hmm.
And so they do those things and they don't think they're wrong because everyone around them is doing the same sort of thing, and you sort of feel that. But Ilka, I have to tell you that one of the things that I've noticed when I listen to ACOG lectures or read their articles or go to their meetings is when they're talking about a pregnant woman, they're never talking about the mind of a pregnant woman.
Mm-hmm.
They're talking about a pregnant woman as if she's a receptacle with a baby inside of her.
Mm-hmm. Mm-hmm.
And that,
yeah.
it's so rare to hear a discussion where they say, this is what we like to do, but we discuss it with the patient, and if the patient doesn't want to do it, then we would go a different way. You never hear that. If you,
Mm-hmm.
you know, I heard Johns Hopkins.
Very totalitarian, no?
You know, it is, but I'm not even sure it's meant in totalitarian is sort of a malicious thing. I'm not even sure it's meant maliciously. I just think it's a cultural thing where it's not taught
mm-hmm.
that a woman's autonomy has any significance. You know, they're working on it, and there's more and more papers coming out and statements coming out about individual autonomy and respecting a patient's choice, and coercion is never acceptable as ACOG's new language and stuff like that. I mean, if only doctors followed those sorts of things,
mm-hmm.
or follow the AMA's code of ethics, which talks about, you know, given two reasonable options, all right, it's not expected that two women, given the same information, will come to the same conclusion,
mm-hmm.
and therefore we have an ethical obligation to support any reasonable choice. Now, if you can label a home birth as not reasonable, okay, then you can argue that it's not reasonable. But the truth is there's enough data in the world literature to suggest that properly selected women who have a home birth or a breech birth or VBAC for that matter or anything else,
mm-hmm.
There's enough literature that says it is reasonable under certain circumstances and certain conditions. And if you ignore that by counseling a woman saying if you have a breech baby, your baby's head will get stuck and your baby will die, and that's all you tell the woman, and you don't tell her about the C-section and about the consequences of having a C-section in her subsequent pregnancies
mm-hmm.
and stuff like that, then you're skewing your counseling and you're being unethical. And this goes on every day in every office,
mm-hmm.
in every hospital across the country.
I mean, I've seen it personally, you know, being a doula in a hospital. I literally had women be bullied into a C-section that were absolutely not necessary because of failure of progress or another like weird reason that was just construed, basically.
Well, and you're so vulnerable at that time that you really don't have much choice, which is one of the things you might want to you were going to ask later, I think, is one of the things as far as importance for pregnant women who might be watching or listening to this is find a team that you trust
mm-hmm.
early in your pregnancy.
Yes.
Do not just go to somebody because that's the guy that was doing your pap smears for the last 10 years. Okay.
Yes.
And a good way to find out sometimes about how somebody is in labor and delivery, if you're going to deliver in the hospital, is to talk to the nurses in labor and delivery. They love to chat about the doctors that they work with. They're always a good resource. So if you move to a new community, one of the things I tell people to do is to call the nurses in labor and delivery to find out who they think the best OBs are.
Mm-hmm.
But again, ultimately, looking at alternatives such as midwifery care is certainly, again, another reasonable option that most obstetricians would just kind of laugh at or scoff at or roll their eyes at, and that is a complete violation of their ethical code to give women options and respect their choices.
Yes, yes. So you became basically a home birth expert, okay? So you decided that I'm done with the hospital, this all sucks, they have all these policies, women have no rights, they're not being respected, and I'm doing it differently, and I'm being the nail that stands out, and I'm going to be a home birth doctor. So your specialty, and that is pretty amazing, is you're doing all the things that certified and professional midwives are, you know, per policies are not allowed to do. And these are things like delivering breech babies. Breech baby means baby comes out with a butt first, or at least with a head last, let's say it like that. And twins and women that go over their due date of 42 weeks. And can you tell me a little bit about, like, how does usually a home birth work? I mean,
yeah, I will. Let me back up for just a second and say,
sure.
Hey, listen, in an ideal world, all right, it would be nice to be able for women who have a breech or twin to be able to deliver in a hospital setting if they were left alone to be labor as nature intended.
Mm-hmm.
One of the things I often hear my colleagues talk about, which of course is mainly just lip service, is they say, you know, they're anti-home birth, but we need to find a way to make the hospital more home-like. And when someone says that, it makes it just just a statement to me that they don't understand birthing at all, because there is absolutely no way to make a hospital more home-like.
Mm-hmm.
Because mammals don't labor well in a setting where there's anxiety, where there's interruption, where there's starvation,
Monitoring,
where there's
yes.
mobilization,
Yeah.
that sort of thing. They just don't do well. And a hospital's policies and procedures are never going to let a woman come into their building and do whatever she wants being left alone, because they're worried about liability, and their risk management department is not going to let that happen. So you can't make a hospital more home-like in that regard. You can do little things like letting them eat a little bit or letting them move a little bit, that sort of thing, but it's still never going to be quite the same as the home. Ideally, if we could have breech and twin births in the hospital setting, that would be fine. The problem, of course, is even worse than that, because not only is it not a great setting for those sorts of things, but even hospital-based doctors who have anesthesiologists are not doing breeches and twins anymore.
They don't know. They don't even know anything about it.
Well, some doctors my age have all been trained in breech delivery. They've just given it up because you know, people can watch the Heads Up documentary. It gives them a quick overview of why breech delivery sort of disappeared. I've got a lot of lectures in that. My friend Rick Safries has done a whole lot of research on data on the term breech trial and all the things that happened afterwards. And there's plenty of data to support breech delivery, but that's being ignored. And so, right, so now the academic programs are not teaching breech, and they're not teaching breech extraction of a second twin. They're not teaching forceps. So what choices do these mothers have, or these doctors have, if they don't know how to do something? They clearly shouldn't be doing it.
Mm-hmm.
But what I would suggest to the next generation of medical students and residents is that you demand from your program that you learn the skills that make obstetricians unique. Because if you don't have those skills, what's the point of being an obstetrician?
Right.
Anyone can do a C-section, and a midwife can do a vaginal delivery. Right. So, and then, and by the way, the laws in California, which again, I know this is going to go wider than California, but the restriction on midwives being able to do breech delivery is sort of just punitive. It's just ACOG and the CMA, California Medical Association, lobbying Sacramento to not allow these people to have these options from women who are well trained, but then they're not offering it themselves either.
Right, so they're completely taking away women's
correct.
choice. You can maybe remember the panel that we had at the Sedona Indie Birth Conference with, I believe there was like 8 to 10 women that actually wanted to have a natural delivery of their breech or twins, and it wasn't possible because they had to either go to the hospital where they immediately end up in a C-section, or they couldn't find a midwife that would do it because they were all licensed and limited that way.
Right.
So, I mean, where is the choice then for a woman to have a natural breech twin or twin birth, which you obviously deliver at home, and they're not all going to be born dead, right? So it works out usually pretty well.
No, very small percentage of them are born dead. No, no. Right? Look, first of all, I would not want to put a baby or a mother or a family at risk. I would also not put my career at risk. So. Right. Like I said, everything that I do is evidence-based. It's just a matter of the fact that people don't like where I'm doing it. But but there isn't really much choice, because I was doing them in the hospital, and the hospital made me stop doing them.
Right.
So one of the major catalysts for me leaving was that case. As far as breech deliveries go, the data is very clear in the literature that if you take a woman who's at term could be anywhere from like 36 to 37 weeks on, and she meets certain criteria, which are well documented, and you have a skilled practitioner, and labor starts spontaneously, and labor progresses spontaneously with the mother and baby tolerating labor, all right, then the chance of a successful vaginal breech birth is over 80%. In primips, it's close to 95 to 100% in multips. Again, properly selected, skilled practitioner, allowing labor to progress on its own.
Right.
And I have found that to be true. And, you know, I have done, I mean, even though I'm one of the most prolific breech practitioners probably in the United States. Even I haven't done that many. I mean, in the last 6 years, I've probably done about 70 breech. I've taken care of about 70 breaches. So what does
That's
that mean?
about 5% of all babies
That's
usually.
like 11 a year, maybe. Right, 3 to 4% of all babies. It's about 20% of my practice, simply because I get people don't have a lot of choices.
Right. So you
But
became a specialist in it, basically.
if you allow labor to progress, it either progresses or it doesn't. And one of my common statements is that breech birth succeeds or not for the same reason that head first babies succeed or not.
Right.
And the only difference about a home breech birth that's not successful at home is that when they go to the hospital, they're going in for cesarean section, as opposed to a head first baby who gets transported, who can go in for an epidural and Pitocin and possibly still get a vacuum or still get a vaginal birth out of the deal. When a breech delivery at home doesn't succeed, my experience and other breech practitioners' experience is that these babies probably should be delivered by cesarean section rather than trying to augment them and push the limits. Breech babies will either come or they won't. And then we now know about positioning on all fours is better. Not all women can push that way or push well that way, but ultimately the use of gravity and the widening of the pelvic diameters and stuff on the all fours makes it far less likely that you have to put your hands on and do anything. There's very specific, and I teach a course in breech birth, and there are very, very specific things. It's not that complicated that help to tell you whether this baby's going to need assistance or not need assistance. And you don't see a sudden deterioration in fetal well-being that you might see at the hospital, where suddenly they go from having a heart rate of 140 down to 80 or something like that. You just don't see that in the home setting, and partly because we're not giving them Pitocin till the cows come home. We're not starving them. We haven't immobilized them. We're letting them have calories. We're letting them eat. We're letting them move about. And when a woman can move about, she can also diminish the need for pain relief, and also she helps her baby out. Women, if you watch women in labor, you've probably seen it. If they're free to move about, they don't just sit still. They move because baby's pushing on this way, so they'll raise one leg up or they'll roll to one side or they'll do things, and that they're helping their baby out. When you give a woman an epidural, you basically remove her, and you make her become just a receptacle. She's just a receptacle now. She's not an active participant in the delivery of her own baby, and that, and there's consequences to that. So I like the home setting because we can't rely on an epidural or artificial means. You have to either do it or you don't. And I think the women that I have that end up with a cesarean section, almost to a woman, almost to a person, are satisfied with the fact that they knew they needed it. Which is a big difference. That when one, the baby gets to choose its own birthday. Two, the idea that you're going to have a cord prolapse or a foot stick out, that's mythical when you've properly selected your clients properly. But that's one of those scary things that doctors will say to women. We need to do your C-section before labor starts because if you start labor, the baby's cord could fall out. All right, and they say that, and it's really not true in term breeches whose butts are well applied to the cervix. It's just not going to happen.
Right.
But
so I remember when you were also teaching a class, or you had a little talk at the conference, and there was a video, you showed a few videos of breech home births, and you started commenting your own doing, basically, and you said, well, over the last years, I actually also learned to be way more hands-off.
Right.
In my traditional midwifery school, we learned actually hands off the breech. That's literally basically all you do. So now you said, well, there's certain things that you would still do to manage. Has that changed in the last 8 years that you're doing home birth and 11 breeches a year? Has your own practice changed that way, that you feel like, okay, now I'm actually way more hands off than I was 8 years ago?
Yes, it definitely has. And it also, again, the beautiful video that's on my website that you've seen, that's shot by Jody Myers. It's called Aurora's Breech Home Birth. She's on her back because for 25 years I did breeches in the hospital, and all women in the hospital in those days delivered in lithotomy position. That's just how we did it. That's all I knew, and that's what I was comfortable doing. So I did it because that's how I was doing it. And so over time, I've attended some breech conferences overseas and talked to some colleagues in Australia and Frankfurt, Germany, and other places in Israel, and learned that there are other ways to do things. And so you begin to do things, and you find that your success rate probably goes up a little bit. But ultimately, as a physician, you have to do what you're comfortable with,
Right.
which is why no physician's going to be doing breech delivery, because even if they saw a couple during residency, they're never going to be comfortable doing them outside. So the idea that we're ever going to really bring breech delivery back in the current model is unlikely. I mean, I have a breech trainer and I can train people to do it, but it's still different when you're dealing with a mother who's uncomfortable and a father who's watching and a live baby whose heart rate maybe dropped to 80, and that's different than dealing with a dummy, a dummy and a model.
Right.
So in this day and age, unless we have a breech centers where, like Los Angeles would be a perfect place for a breech center. If you think about it, I'm not saying that every woman who has a breech baby should even want to have a vaginal birth, and they're not all candidates for a vaginal birth. But if there's 120,000 births every year in LA County, all right, that means that what, 3% of those, that's what, 3,600?
That's
Something like 3,600 breaches a year in Southern California, of which maybe 30 or 40 deliver vaginally, right? But if we could get 10% of those, okay, that would be 320 breaches a year. And then you go to residency programs and you say, okay, send me your resident for 2 months and I'll get him, what is that? 320 divided by 12 is what? 25 a month, 26 a month.
50,
so yeah, I'll get you 50, you'll get you 45 or 50 breech deliveries. It would be so easy to do.
Right.
And the reason that you need to teach breech delivery as a core skill is because still 20% of breaches are diagnosed at crowning, and people don't know what to do. And so what do? They do a crash C-section if they have to. I mean, how many sad stories do you hear about women who came in, they're ready to push, they start pushing, and the butt's coming out, and then they tell the woman to stop pushing. They call it crash C-section. Takes 20 minutes. The baby's been out already. It takes 20 minutes to get the C-section going. And then they still have to push the baby up and deliver the baby breech through the abdominal incision.
Oh my God.
So they still have to know how to do a breech birth, because if you don't know how to do a breech birth, you can injure a baby badly doing a breech C-section.
Totally.
But they don't teach the skill. And if you don't teach the skill to young people, old people, when they get older, they're never going to do it. Yeah. So
you would say a woman that is pregnant right now and she decided to have a home birth, and she finds out she has a breech baby. The world is not breaking down for her. She doesn't have to necessarily go to the hospital and get a C-section. There is different options for her. She can be at home, and she can be at home safe.
Yes, it can. There are certain considerations for that, and I'll go through them. I mean, first of all, one of the issues that happens sometimes is financial. I mean, I'm the only one that's doing that. I don't take insurance. That some people can't afford that sort of thing. I get it. There are a couple guys in LA that do breech delivery at the hospital, but they'd want to meet you sooner. What I would recommend for people is to not panic about breech birth at all if their baby's breech at like 32 or 33 weeks. But by 34 weeks, if your baby's still breech, you could start to do some of the exercises that Spinning Babies offers. You could start to see the chiropractor. You start doing the Webster technique. You do acupuncture, moxibustion. Try to get the baby to turn. The problem is now, since nobody does vaginal breech birth.
Isn't there? I always feel like there's a reason why a baby.
Yes, well, that's what I was going to get to.
Right?
The problem is that since women don't have an option of vaginal breech birth, the idea of an external version and forcing the baby to turn is very important. But I will tell you that when I meet a woman who's breech, who has the confidence in me after our meeting, and I offer them an external version, a lot of them will refuse it because they say, hey, my baby's been breeched. It's been breeched all along. She wants to come this way.
Right.
And now I've got an option, so I'm going to do that. But a lot of people don't have an option. and so they go for external version. The hard part about external version is you don't know how good your physician is at doing them.
Right, right.
Right.
And there might be actually a real reason why this baby is breech. It might have not enough space to turn or whatever, right? I mean,
well, the success rate of versions, especially in women having their first baby, isn't very high.
right.
But ultimately, if that's your only choice, that or a C-section, then a lot of women will go and try for an external version. But it shouldn't be your only choice.
Yeah, exactly,
Right.
exactly. It shouldn't be. So how can a family or a woman actually, in your opinion, prepare best for a home birth in general, not necessarily only for a breech birth or a twin birth, but in general? How would you say, hey, if I'm like, say, I'm 13 weeks today, I would be with a hospital and I have a doctor and he's the guy that always did my pap smear, but I'm watching this interview and I'm like, holy shit, I guess I'm not having like the best options if I'm going to a hospital, because it kind of sucks and I don't really have a lot of choice there, and I might be feeling pretty disrespected. And what would be my best choice to say, okay, I'm actually not going to be in a hospital. I'm not going to be a doctor with a doctor. With a doctor in a hospital, I'm going to plan on a home birth.
Right.
How would I do that?
You look up, you could just, for your community, you could just Google home birth midwifery, and then you'd find the midwives in your area, and then you go interview them, and you find one that you seem to have good compatibility with. Because ultimately, feeling safe, feeling secure, feeling trust, having a bonding relationship goes a long way to success. I would recommend that all first-time mothers have a doula, and I recommend that they keep at a distance all the naysayers.
That's a good one.
This is important because, you know, if you start to tell your mother or your cousins or your co-workers that you're planning a home birth, you can expect to get mixed results with that. And if you're capable of dealing with that, that's fine. But if you're not capable of dealing with that, or the negativity is going to start to play on you, or the anxiety is going to start to play on you, that's not helpful. Mammals don't do well in pregnancy and labor when they're anxious. So you want to surround yourself with supportive people. And if you have a good trust,
like-minded community, right?
If you have good trust in your practitioner, I will say she, because almost all midwives are she is going to tell you if you are a good candidate to continue your prenatal care and plan to deliver at home. And because midwives are such experts in low-risk normal birthing, they're very good at spotting things that are abnormal. And that's a really interesting thing that people think about. They think like doctors are trained in birth as illness, birth as disease, birth as problems. And that's how they see every birth, even if it's normal. Midwives are trained in birth as normal. And when you're trained in birth as normal, when something isn't normal, it jumps out at you very, very readily. So, your midwife has your best interest at heart. It isn't about greed, or it isn't about ego for them. It's about giving you the best experience possible. And your midwife doesn't necessarily abandon you if she feels like your care should be transferred to a hospital-based practice. She may very well stay with you through that whole experience and still provide you that nurturing prenatal care that you can get in the midwifery model. Because I'll tell you that one of the biggest differences for me was the style of prenatal care that I learned as a resident, which was actually prenatal visits are about 5-6 minutes long at the most.
Ultrasound test, pee on a stick, blood pressure, and weight gain.
Yeah, and that's
That's
it.
about it.
And that's it. I'll see you in 2 weeks. Whereas the midwifery model, the prenatal visits are about an hour long, and there's a lot more involved in preventative care and nutrition and sleep and stress reduction and all the things that make the pregnancy more likely to extend to term and to have a better outcome, because it's instilling confidence in the pregnant woman. That sort of thing is not taught in medical school or residency. I didn't have a single lecture, and I don't think it's changed, but I didn't have a single lecture on nutrition or breastfeeding in 4 years of residency.
Wow.
And also, midwives train as mother-baby as a unit, whereas OBs train as mother is pregnant, baby comes out, baby's now part of the pediatric department, and I don't have to deal with that anymore. And mother-baby are always a unit in mammals, and they should never really be separated unless there's a real ultimate problem. But that's not the way it works, and the hospital doesn't look at it like that. The pediatric department has swooped down into the newborn nursery and has taken jurisdiction over newborn babies, when really their mother-baby and ultimately mother-baby are best treated by the midwifery model, which transitions beautifully from being pregnant to being skin to skin, to being latching, to nursing, to growth, to how many pees and how many poops your baby has. I mean, I don't know a single obstetrician other than me that has ever asked a woman at her postpartum visit how many pees and poops your baby's having. And plus, the way the medical model works also is that, say you have a vaginal birth at the hospital and you go home on the second day postpartum. When does your doctor see you again?
6
weeks
later.
6 weeks.
Hell.
Okay. Right.
Yeah.
All right. That's ridiculous, because in that 5.5 week period of time, a lot of things are happening. But your doctor's not trained for that period of time. Doesn't really know much. And at 6 weeks, you talk about a pap smear and birth control.
Yeah,
And
I'm actually going to have an interview with Rachel Garcia, who I believe you're familiar with as well. And she is all about the postpartum period and why it is so sacred and so important to set up not just a healthy baby, but also a healthy mom for the rest of her life, right?
Right. And here's another clue for women that don't really want to have an out-of-hospital birth, but want to have a home birth. One of the things that you can do, which no one ever thinks of, but you can hire a midwife and have collaborative care. And you can hire her as what's called a monitrice. Monitrice is somebody who can come to your house. It's not like a doula. Doulas can't do anything medical. A monitrice can come to your house when you're in labor, can monitor the baby, can monitor your vital signs, can do a vaginal exam if necessary, and can just try to keep you home until you're like 9 centimeters dilated, at which point you go to the hospital. You do not want to go to the hospital the minute you start contracting or the minute you break your bag of waters. But most doctors will tell you, if you've been contracting for 2 hours or if your bag of waters breaks, you need to go to the hospital. And that is absolutely the wrong thing to do 99% of the time. All right? It is, because what happens once you're in the hospital.
Cascade of intervention.
That's correct.
Yeah, totally.
Yeah, that's correct. They don't know. They don't want you sitting there doing nothing. All right? They don't have the room for that. So they're designed that you're here now. Your membranes are ruptured. Oh my God, you've got 24 hours before the bacteria start to, look at the bacteria all looking at their Apple Watches and saying, we've got about 16 hours, Fred, before we start to multiply like crazy. So, like as if bacteria know these sorts of things. And there is no, again, those are false time limits. The whole thing about 24 hours of ruptured membranes or 35 years old or 42 weeks, as a blanket statement, it's ridiculous. There are certain times where that's true, but there's nothing special about 24 hours. Why not 23 hours? Why not 27 hours? 24 hours is just a number that we pick because it's the number of hours in a day, but bacteria don't know from a day. And somebody who's 34 years old in 11 months doesn't suddenly become different at 35 years old. But if you're labeled that way, then you start to think that much. We talked about that earlier. So if you want a hospital birth, one of the things you can do, and I don't, again, some of it comes down to money and insurance and coverage.
I would much rather say, if you want to have a home birth, what are you going to do then? Because that's what I want to actually teach women, is how to get the heck out of the hospital, how to be not one of these 99% anymore, but rather take responsibility and find the right team, as you said, and find the right either doctor or midwife or whoever she wants. If that is a free birth, if that is her choice, that is her choice as well, right?
Well, consider that the hospital should not be the first choice for most pregnant women when they go into labor. And that culturally is something that has to change, because, 75 years ago, everybody delivered at home.
Right.
And now everyone delivers in a hospital. And that was a cultural shift. It was purposeful. There was a campaign by the American Medical Association to vilify midwives and to talk about how beautiful it is to have, aluminum based, these shiny new birthing rooms, and you can have your hair done after your baby's born, and that sort of thing. And they built it that way, and they did it. It didn't have any medical science behind it. It had some empirical things like, well, you're closer to an operating room, that makes it safer. But there was no stage 2 thinking when they did this. It was all stage 1 thinking, and they didn't realize that all these interventions have raised the C-section rate in the last 45 years from 5% to 32%, with nothing really to show for it.
That's insane.
So if you want to, most women do not need to birth in the hospital, and we need to change the culture so that they understand that. And if they start out with a midwife, all right, then they're going to find that probably 90% of them are going to be able to stay with the midwife and have the birth that they want. They may end up transferring the hospital in labor, but at least they're going to have the birth and the experience that they want throughout all the prenatal care and throughout the early part of labor.
And transfer rates in general, and I don't want to really get into that, but they're actually not that really high. Like not a lot of women that actually be birthing at home, have a planned out of hospital birth, have to at the end transport to the hospital.
Yeah, I can give you numbers on that actually. It's about 20% of first-time mothers who will end up transporting, and about half of those mothers will end up still delivering vaginally.
Perfect.
So the C-section rate for first-time mothers is about 10%.
Wow.
Whereas if you walk into the hospital, a first-time mother just walking into the hospital in labor with no medical problems at all has about a 24% chance of having a cesarean section. So it's 2.5 times higher simply by the model by which they care for. Wow. And if you're a multip, which means they've already had one vaginal birth, your chance of being transported is about 1%.
Wow.
All right. It's very small. And I will tell you that even though transports are rare, most common reason for transports are not in labor, they're postpartum. Breathing, or the baby isn't breathing well and needs a little more assistance. And again, your midwife and your midwife team are trained to deal with babies that come out needing assistance. They're trained to deal with bleeding. They carry medications. It isn't like they have a box full of herbs and that's it. All right. They carry medication, they carry oxygen, they carry Pitocin, they carry antibiotics, they carry a local anesthesia, they carry suture material, they can fix things, they can do all these things. People don't know that about them. Right. So if one thing that can come from this interview is that women should, at least before they choose to have a hospital birth, look into the option of a midwife-based out-of-hospital birth and find out if it's for them.
Right.
All right. And if you look at all the information and you make a decision that a hospital birth with your obstetrician is what you want, then you've made an informed decision. But if you do it because you're feeling coerced or because you're feeling it's dangerous and this is the safest thing,
or it's the culture, that's just what everyone does.
Yeah, safety is a hammer by which all totalitarian people force you to do things that you don't want to do. All right. I mean, they do it. I mean, the parents do it to their kids. They use safety as a thing. The government does it to its citizens. Right.
And the hospital does it to birthing women. That's for sure. Stuart, we have exactly 5 more minutes before we get interrupted. I also want to be respectful of your time. We're already talking for an hour, which was like, it flew by like no time, because everything you're saying is just like, first off, I'm totally on the same page. And it's just really wonderful to see someone that, actually stands out and questions things and does things differently and stands up for women and gives women choice. That is really amazing. So my very last question, before I wanted to know how we can find out more about what you teach, where you teach, how we can, get in touch with you. If this would be your last day on earth, what would be the most important thing you would like to share with a pregnant woman today?
Okay, so you're narrowing me down to sharing with a pregnant woman.
Yes.
Okay, if this were my last day on earth, and the thing that I would like most to share with pregnant women would be that pregnancy is not an illness, that it is a natural function of your body. You're designed to do this, and you and all your other pregnant women need to rethink the paradigm that we've unfortunately set up in Western civilization to make birth this scary thing. The best thing that you can do for yourself and for the next generation of your daughters is to sort of reteach the idea that most birth is normal, and normalizing birth for the next generation. I'm going to digress for just a second, but
please.
But when you look at birth, you can also look at death. Mm-hmm. What we've done in the last 50 years is we've sterilized them from our society. Mm-hmm. Most families, most people our age or younger have never seen a birth, and they've never seen someone die. Mm-hmm. All right. When I was young, my grandfather died in our house. We were all there. And if it, when I see these beautiful pictures of a home birth where the other two kids are like watching,
Yeah.
right? And they're hearing the noises that mommy's making, and they're seeing their newborn brother, and they're seeing the blood and the cord and all that stuff. It's going to normalize it for them, and it's not going to have this mysterious, scary thing that that culturally we've made it, and there's advantages as to why academic medicine and the industrial medical complex have done this sort of thing, and that needs to change. And so if I were to, as you say, move on to off this earthly plane in the next 24 hours, which better not be a prediction. I have no intention of going anywhere for a while.
No, we need to hear.
But I would say that teach yourself, teach your daughters, all right, and the men too, okay.
Yes.
But that birth is not something to be frightened about. Think about how this whole process works. It's a miracle from the moment that your pituitary gland tells your brain, your pituitary gland tells your ovary to make a follicle, which releases an egg, which then combines with a sperm and takes a couple days to travel down the fallopian tube and implant in the uterine wall, and that one cell can then divide, becomes a human with teeth and pancreas and liver and skin and eyeballs, all from one cell. And it knows how to do it, and it does it right most of the time. And that you grow, and every other mammal on Earth doesn't have this sort of system that we have that we've meddled with humans. Your dog, your cat, a deer, a horse, when they're in labor, they go off to a quiet place by themselves. Nobody bothers them. They eat if they're hungry. They lay down if they want to lay down. They stand up and pace if they want to. When they give birth, the baby falls in the dirt. It's not a sterile procedure. Nobody comes in and cuts the cord. No one ever separates the mother from the baby. The idea that when I first started training, that I would catch a baby fully garbed in my hazmat gear. I would catch a baby. I would hold the baby in one hand, fumble with some clamps to immediately clamp the cord, cut the cord. Then I would hold the baby up to the mother. There's your baby. And then guess what I would do with it? I'd turn around and I'd hand it to the nurse behind me, who would take it over to the warmer.
Wow.
Ask yourselves why we do that.
Right.
And if you ask a nurse why she does that, she will not have an answer for you. Mm-hmm. They don't know. It's the long habit of doing something or not considering something wrong that gives it the impression of being right. And for far too long, 3-4 generations of American women, we have considered birth to be this dangerous, scary medical procedure, and it's not, except when it is. And when it is, your practitioner will know it. And
you will know it. Moms will know it as well.
And you will know it too. But yeah. So that's what I'm saying. So if I were to be gone tomorrow, my legacy I would like to be is that for the families that I have touched and the people that hopefully will be watching this and other things that I've done, that they will start to realize that we need to change the paradigm for the sake of our daughters and our future grandchildren and stuff. We need to change how we view birth. We can't go on with a 30 to 40% cesarean section rate. It just we don't know the long-term damage that's going to have. Not to mention the psychological damage it has to women who every day, if you go to an ICANN meeting, you got women who are traumatized by what's happened to them. And that affects them. It affects their ability to mother. It affects their ability to be a good partner for probably the rest of their life. And it's a shame. Yeah. And nobody considers that. It's not considered in the obstetric world. They pay lip service to it. There's words to it, and there's guidelines to it, but that's not what's being practiced. Every single day across the country, there are ethical violations in every office, in every hospital, and there are violations of every hospital's mission statement by the very hospital itself. I mean, if you read a hospital's mission statement, it's always about respecting a patient's decision and autonomy and blah, blah, blah. And then they go ahead and they coerce you into doing stuff that you don't want to do, and they make you think that your body is a failure because because you're not moving fast enough. Well, who decides what's fast enough?
Right.
So that's sort of it.
Wow. Thank you. Wow, this was a great summary of, I mean, your legacy. That's why you need to actually stay here for a long time, to keep on working on that and keep on spreading that word. And I hope that I can, I'll be able to help you spread this word word into the world with this interview. Amazing. Thank you so much for coming on here today and like taking an hour of your time. I know you're probably super busy, and chatting with me about this. This is super important stuff. And I hope not only, pregnant women will see this right now, even though that's probably likely the case, but any other one that knows a pregnant woman, a partner or a doula or another midwife or a medical student that thinks, about being an obstetrician and maybe changes his mind a little bit on how he or she is going to practice in the future. So thank you so much for this. How can we find out more about you? Your website, or do you have any?
Yeah, my website is the best way to start because everything is there. It's www.birthinginstincts.com.
Ooh, I like that. I will definitely write this down on this.
There's links to some paper I published, and there's links to some videos, and there's how to contact me. I have a blog where I post stuff where I have some of my clients who've written their birth stories will post them there. People who want to read a little bit more about breech delivery or twin delivery. There's some great testimonials and great birth stories on the blog page. I also have a podcast. It's called drstuspodcast.com. That's DRSTUS. DRSTUS podcast.com. There's a link to it on the Birthing Instincts Facebook page. Birthing Instinct website. And then, of course, I have a Facebook page where I post stuff. But ultimately, that's the place to go. People can hear me once or twice a month. We do a podcast on some topic. We've done 126 of them now. If people are really curious to get to know me a little bit better, they can start with number 1 and work their way through.
Totally. And, people find you randomly on YouTube, as I did, like, who are these male hands at the breech birth?
YouTube or, YouTube or the internet is another way to find it. And again, we have people sometimes who travel to Southern California in the last month of pregnancy. It's not ideal, but we've had twins, a couple of sets of twins from Colorado. We've had a VBAC from Oregon. Come down, they get an Airbnb and they stay down here because of the lack of choices in their community.
Wow.
And so there's always that
travel
option.
All over the country to get in touch with you.
Well, not a lot, but they do. And I also travel all over Southern California. I'm getting tired of doing that, by the way. And that may end soon. I may end up just trying to pick a place and like work at a birth center or something and have people come to me because I am getting a little older and spending 3 hours in the car to drive to some birth someplace and being nervous all the way down there because I'm stuck on LA traffic is not a great thing to do.
Oh gosh, yes.
So
terrible.
yeah, and ultimately I'm getting into more teaching.
Yeah, that was my last question. Like, if we want to learn more from you as doulas, as midwives, how can we?
Well, on the Birthing Instincts page, there's a calendar, and you can see what's coming up. But my next thing on April 13th, I'll be in Santa Barbara at a women's health forum. It's a Friday night, I believe, and then on the 21st, which I think is a Saturday, I will be in San Diego doing a breech seminar.
Nice.
And you can find these things on the website. And then in May, I'm going to Portugal, and I'm going to be teaching 2 breech seminars in 2 different cities, Porto and Lisbon, which is a thrill for me. And then in the fall, we're going to be going to Utah and to possibly Alabama and Georgia. That's the thing I'd like to do. I can't make a living teaching, but I certainly like doing it. Because what I'm doing and what I'd like to do is be able to teach medical students and residents, as well as midwives, of course. Mostly what I've been doing is teaching midwives, and because they're eager to learn the skill. And I think that residents are eager to learn the skill too. It's just their academic programs won't let them.
Right.
So we have recently gotten CME approval. So now I can give lectures where I can offer CMEs to doctors and to medical students and residents, which is a big thing because before that, we only could offer CEUs, which is what midwives get. And people who are going to take these courses, they sort of want to get some credit for it because they have certain requirements they have. So they might as well get some credit for it. So we're going to start to do that. So people can follow that on the calendar page and on my Facebook page also, Dr. Stuart Fischbein, OBGYN Facebook page, which also will have upcoming events.
Yeah,
And I
and
would
I
love
see
to.
you're pretty active there. It's always updated, so you can definitely find.
I'm not a very good social media person. I have somebody that does it for me, but I don't tweet, and I haven't done Instagram, and I've been prodded so many times to do it. But ultimately, you know what, there's only so many hours in the day, and I really am not getting into that at this point yet. But if I were to actually get some assistance, another physician to work with me where I wasn't always on call, the hardest part about doing what I'm doing is that I'm on call 24/7
Mhm.
for my clients all the time, because if a breech or twin labor woman goes into labor and I'm not available or out of town, she has to go to the hospital.
Right, right.
Whereas my midwife colleagues, if they're out of town, another midwife can cover them. Nobody can cover me because of the California law.
Yeah,
So, and you know, and somewhere down the road, might I consider moving to another state? Yeah, those sorts of things. But there's only one of me, and I'm trying to make more of me. But it'd be very, very difficult because the people coming out of training now just don't have the skill or confidence to do what I do. And it's going to take somebody who has a real strong burning desire to finish their residency and then come and say, I want to come work with you and learn. And then that would be great.
right.
You're not going to get rich quick doing that, and that's the problem. And I think that a lot of people come out of medical school and stuff with a lot of debt, and
That's
therefore,
true.
and then they can't afford to do that thing, or they're scared, or nervous, or the people around them are nervous, just saying, you know, you can't do home birthing. It's you're nuts if you do it. So anyway, I got off track. Birthinginstincts.com. That's where you'd find me.
Thank you so much. This was amazing, super informative, and I'm so excited to spread this around. So please, I will send this to you, and you can spread it as well. And I hope I will get a chance to see you in person sometime, maybe at the next Indie Birth Conference, and give you a big hug.
Maybe so. Tell the team down there. And listen, your energy is infectious. I've enjoyed this hour very much, because I'm going to hang up with you now, and I'm going to feel really good about this talk that we had, because partly because of the feedback I'm getting. The thing that keeps me going are people like you.
Hell yeah, same. So thank you so much.
You're welcome.
Have a wonderful rest of your day.
Okay. Bye-bye.
Bye.
Thank you, ladies, for joining us to this great interview. If you enjoyed this, please follow the Liberated Birth Movement on Facebook or subscribe to our channel. If you have more questions how to apply these ideas to your pregnancy and birth, schedule a call and we'll get you clear on what you want and how to get it. meetme.so/liberatedbirth. meetme.so/liberatedbirth. Always remember, birth belongs to women.